Alicia Feist of the Arizona College of Optometry, and I serve as chair of the ASCO Clinical Affairs Committee, which is bringing you this forum through the support of the Clinical Directors Administrators SIG. Today's topic is communicating with students in the clinical setting effectively and precepting the struggling student. I'd like to acknowledge the Clinical Affairs Committee members, Dr. Don Godey, Dr. William Hefner, Dr. William McGovern, Dr. Maria Parisi, Dr. Amy Moy, and Dr. Gregory Waldorf, and the Clinical Director SIG representatives. Thank you to our 2022 OSIF co-chairs, Dr. Valerie Katouf of ICO and Dr. Amy Moy of NECO. Both volunteered to steer this program and effort. Also, thank you to each of our presenters and to Ms. Carol Brubaker, our Clinical Affairs Committee staff liaison and manager of professional affairs at ASCO. Additional thanks go out to Sarah Lau at ASCO for her help behind the scenes today. They've all been instrumental in bringing you this forum. And lastly, we want to thank our on-site OSIF liaisons for helping spread the word about this amazing event we have for you today. Just a few requests. If you're watching as a part of a group, please make sure that each attendee signs an attendance sheet and sends those sheets to Carol Brubaker at ASCO. Also, please take a moment to double check that you're on mute and remain on mute unless you're engaging with the presenter during the Q&A portion of the program. Please keep your camera on if you are a presenter or a moderator. This meeting will be recorded for posting on ASCO's YouTube and website, and Ms. Brubaker will send you a SurveyMonkey link to each registrant shortly after the conclusion of the program. Please complete the survey so we can utilize the information to better meet your needs and for future planning. We have 4 excellent sessions prepared for you today, so without further ado, I'd like to introduce our 2 OSIF co-chairs, Dr. Katouf and Dr. Moy. I will now turn it over to Dr. Moy.
Thanks so much for the introduction, Dr. Feist. Before I introduce the first speaker, I want to thank the Clinic Directors and Administrators SIG for their sponsorship of this important biannual forum that brings clinical educators together. An exciting initiative from this SIG this year was the formation of a subcommittee to design a clinical preceptors toolkit that will be housed on the ASCO website. This preceptor toolkit is being developed as a resource for training new preceptors and enhancing the clinical skills of the teaching skills of current ones. So we continue to work on this project and anticipate releasing a portion of it in the coming months, and we can't wait to show you. For a few housekeeping items, we again ask that you all check now that you are muted and remain so throughout the duration of the OSEF, unless you are asking a question during Q&A. Please hold your questions until the end of each speaker's presentation because we've built time into the program between each panel member for questions. You may put your questions in the chat, or you can use the raise hand feature in Zoom if you prefer. Just remember to remove your hand raise after your question has been answered. And now, on to our forum. We have 5 wonderful speakers from 4 different optometry schools. These speakers were invited to this panel because of their expertise in the area of precepting the struggling optometry student. Thank you all for being here today. Our first speaker is Dr. Amy Steinway. Dr. Steinway is currently an assistant clinical professor at SUNY. Dr. Steinway is responsible for the clinical supervision of 3rd and 4th year students in primary care and vision therapy. She earned her Doctor of Optometry from SUNY in 2015. She completed her residency in primary eye care at SUNY Optometry in 2014. Dr. Steinway is the instructor of record of the 2nd year clinical optometry course, assistant chief of the primary care service, and the coordinator of the clinical enhancement program for students who struggle clinically. She enjoys spending time with family and friends, trying out new recipes, and going for walks in Central Park. Dr. Steinway will be speaking with us about communicating with struggling students. Again, please hold questions until the end and bear with us as we need to stay on schedule so we can hear from each speaker. Dr. Steinway, thank you for being here, and I'll turn it over to you.
Thank you, Dr. Moy, for that introduction. We got some Amy power today, so very exciting. Today I'll be talking about communicating with struggling students and some good practices for us as supervisors. A quick outline for what I'll be discussing today. So setting expectations. We need to give our students specific guidelines, a rubric maybe to give them a layout for success. Sometimes struggling learners might be scatterbrained, so this is a way to help give them a concrete kind of layout. Listening to the student concerns. Is there high anxiety? Is there stress? Are they uncomfortable with certain techniques? This is what we'll look into today. And then managing patient flow while we're working with struggling students. So what can the students do on their end as struggling students? And what can we do as preceptors to manage that flow? So some areas for struggling learners. So these are recognized categories that are potential needs for remediation. So based on these different areas, your discussion or communication might be different with each type of these students. So let's jump into setting expectations. Again, giving that explicit guidelines. So having that grading rubric handy for students to reference and go throughout their time. If they're struggling in a certain area, they can go back, check the rubric for the areas that maybe you've mentioned in your feedback. And in writing, they can see what's expected, and this gives them a guideline for how to succeed. Criterion-based assessments or benchmarks of performance are typically more so done in the labs in the didactic portion of the student's learning experience. But while they're in clinic, do we need to observe certain techniques that they are working on improving? Do we need to have them practice outside of the clinic? So thinking about ways to assess those areas. The student handbook is actually a good reference and has resources if your student is struggling in areas of professionalism or communication. It does have some good guidelines of what professionalism is and what we have expected of them. You want to give examples and feedback to these students. And Dr. Riley later on in this presentation will be discussing feedback, but it is very important and these students crave it constantly. So it's very helpful for the struggling learner. We want to remind these students that they are responsible for their previous knowledge. You know, they've gone through all of the coursework. They need to review their notes. Students often ask, is the final cumulative? And one of my colleagues came up with a great answer. Being a doctor is cumulative. So we need to constantly know a lot of facts and information. So being able to reference that and having a good knowledge base is really important expectation for these struggling learners. So here are some different communication styles. You want to be thinking about which one you are, and maybe if we need to adapt or adjust the communication that we have with these students. So are you the assertive style? It's very teacher-centered. You're asking direct questions, almost like a quiz or a test in a way. So this is an area where struggling students might not excel. They might feel attacked or that they're being quizzed on the spot. Some students don't like that and they struggle in that area. So is that working for your struggling student? Do we need to switch gears? So we also have the suggestive style, and that is when we are sharing our opinions and our experience based on our clinical encounters. So it's a little bit more of a calm manner, a little bit more passive learning in a way. So that might be more receptive for students who are struggling or need more information. The collaborative style, this is even more learner-centered. So you're exploring the learner's ideas and hearing from their perspective and their learning from that encounter. There's also the facilitative style. This is beyond clinical content. It's heavily feelings based. So is this an area where the student is getting anxiety or struggling in a professional manner or with some communication perhaps? So an interesting technique if you need to switch gears. Other options for communication when you're giving feedback. I know many of you probably already know the sandwich method. So you're giving a piece of potentially negative feedback, an area where the student needs to grow, but you're sandwiching it, you're putting it in between two positive feedback comments. So an example might be, you did a great job with your refraction. However, your cover test results were off, but then you thought to go back and recheck the ranges. or something along those lines. And then you always want to hopefully end with an action plan for the student to give them something to work on for the next time. So an example here might be, I'd like you to go practice cover test on 10 people before you come back to clinic so we can get your cover test to be accurate. So that's one method. Another is ask, tell, ask. So having the student reflect. So how do you think you did today in clinic? Giving them feedback, both positive and negative, and then having them reflect on that feedback. So, what do you agree, or what can you do next time to be better or, improve in that area? And again, ending with that action plan. So here are some best and worst practices. So ideally, we want to be specific to our expectations as mentioned. We need to hold our interns accountable with keeping in mind what level they're at in their experience. You're going to be holding interns accountable in a different way if they're a new third-year student versus a seasoned fourth-year student. So keeping that in mind. Giving them, timely, accurate, almost they really want this constant feedback. That's what we've been hearing. The students want to know how they're doing, especially if they're struggling, they want to reach their goals. So document feedback in written form, that's very helpful for them to go back and check. Making links to curriculum where possible as well. Things to try to avoid when possible when communicating with these students is comparing interns to each other. Some students are slow learners. It's not a good idea to really compare one to another. And then holding them to impossible standards, judging or assuming motivation, predetermining ability, and providing all answers to your questions is actually not ideal. You want to give them a chance to show you what they know, or let them reflect and think back for a second. They might not have it right away, but give them a second to kind of think and reflect. And then noting the need for improvement without providing guidance as to how to make improvement. So really giving that guidance or making that action plan as we discussed previously. So switching gears a little bit, talking about listening to concerns. So does the student have low confidence? And this is something that we will be speaking about later as well, having the confidence. Are these students making excuses? What can we do to help these students improve their confidence and reduce the number of excuses? If they're late to clinic or to class, can they take an earlier train perhaps and try to get there earlier, or train in New York? I don't, maybe driving earlier everywhere else. Not responding to emails. Is there something they can set up on their phone as a reminder to reply to emails in a timely fashion? But then you want to think back, is there a reason why these issues might be happening? Are these students suffering from anxiety or high nerves? I mean, during this time, things have been crazy. Students are high anxiety, very anxious these days. So you want to think about, is there another personal issue going on? There might be an issue with their private relationships, family. So you want to take a step back and really talk to the student, see if there's anything going on that you weren't aware of that you can help with, and just generally treating them with respect. And then we want to address these concerns and we want to take them seriously. So up to 25% of students do have anxiety. We want to offer that validation and acceptance. We can offer, we have, the student center here who can offer help, acknowledge their feelings are understandable, and offer help when we can. We want to avoid shaming or calling out students in front of others. We do want to encourage the student to tell you if they are struggling. You can preset regular check-ins. Weekly in clinic, you can just see how the student is doing and develop that game plan with your student as a plan for success. And then again, being mindful of how you communicate. So we did mention some of those methods earlier. Switching gears a little bit to managing patient flow. So on a busy day, how do you handle a struggling student who might be taking a longer time with their patient? Their exam seems to be dragging on, and stacking patients can be very overwhelming for these students. They get lost in the shuffle. If one patient case is more complicated, it throws them off potentially. So we want to provide ideas and methods for organization, which actually Dr. Blacker will touch on a little bit later as well. So maybe perhaps if it's the time issue for them, setting a timer, giving them, specific guidelines. I will give you 10 minutes for refraction. Come back and let me know what you get. Or having them literally use their phone or watch to set a timer, depending on where they are in their clinic. If maybe I'll give you 45 minutes up until dilation and then come back. So really giving them those specific guidelines as methods to succeed. So what can we do as educators? Again, just creating that action plan. There's some certain methods that can be helpful. So a 1-minute preceptor option, which I'll go through an example, can be helpful. If there's time, the Socratic method, where you're drawing out the answer from the student, you keep asking questions and not giving those answers. Again, sometimes it works with struggling students, sometimes it might not. So being flexible and changing as well. And then if the student requires additional practice, maybe asking for another clinic session for them to get more patient encounters to be able to practice these skills that you're working on with them. So the 1-minute preceptor, again, is a fast-paced, really quick method of getting the student to arrive at certain conclusions. So you want to get a commitment. Does this make sense? Probe for evidence. Is this consistent? Reinforce what was well done. This is good, positive feedback for them. Give guidance about what went wrong, and then teach an overall general principle, and then giving a conclusion or summary of that case with them. And if anyone is interested, there is a quick YouTube video link below for you to watch on an example of the 1-minute preceptor. Again, this is a tough thing to do, communicating with a struggling student. The one thing I can tell you is to have patience, 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 and even more patience. This is a tough subject. You want to never run out of patience, and maybe a little bit of a positive attitude can be really helpful as well. I think we'll send out the link to the YouTube video in the slides, and this is also recorded. And we don't have time to watch it today, but hopefully you'll get to see it soon. Summarizing communication. So someone at Purdue had a really great acronym called CARE. So communicate compassionately. We care about our students and we want to show them that. Allow flexibility and communicate the why behind certain deadlines, or why you might need them to be more accurate in clinic or be more efficient in clinic. Reevaluate, see where the student's at after a little bit of time. If they're improving, see what they need to help them improve. Empathize and elevate. And so this is just a great acronym to continue working with these struggling students and communicating properly. And then just to kind of flip it to us, these are most helpful teaching behaviors from a student perspective. So these students have almost set specific guidelines for us on what they would like from us. So they want a preceptor who takes time for discussion and questions. They want a teacher who answers questions clearly, who provides constructive feedback. They want someone who provides students with opportunities, is willingly accessible to these students. They want someone who discusses the application and knowledge. They want someone who shares their experience. So these are very specific guidelines. It's obviously hard to be all 10 of these on every day when you're in clinic on a busy day, but these are the hopes. This is the guidelines that our students have hopefully set for us, and maybe how we can improve being better educators as well. So just again, thinking about how we can improve as educators, we want to remember our goal. We are helping make this future provider a better clinician, and just having that patience and being there for them and understanding all these areas where we can help them improve. So are there any questions?
Thank you so much, Dr. Steinway.
Thank you.
Really great start to our panel. I will open it up to 1 to 2 questions before we move on to the next topic. And if your question is actually being addressed by a further panel speaker, I might ask you to hold on to that. But does anyone have any questions?
I have a question. Hi.
Hi.
So thanks for your presentation. So I know it seemed like most of the presentation discussion was sort of focused on, what we as preceptors can do to interact with the students and have those interactions be more productive and, learner centered. But what are your thoughts on and recommendations for teaching students to be more reflective and self-aware? Because I know specifically one of the things you mentioned was about, providing feedback to the students and talking about, giving them specific feedback on what their performance was like. But I think part of that is also helping the student to cultivate self-awareness, because very often those two perceptions are mismatched, where the student is very unaware of how their performance is not matching, their perception of their own performance does not match the perception of the preceptor's performance of that student.
Right. That is a very tricky thing to do. Some students obviously take it better than others. Some students are just better, they're more self-aware and they take in feedback a little bit better. But with those who struggle, I mean, it's tough. We've had examples where we actually can video record students during an exam with the patient's permission. And so the students are actually able to watch their performance back and see areas, and you have like a concrete example then in front of you to show the student, maybe we could do it this way instead, or, I'd like you to do this technique a little bit differently, but that might be one method. And then again, just the more concrete examples you can give in the feedback, and the more constant you can do that, I think the better, but that is a very tricky area. Hopefully that helps.
Thanks.
Good question, Dr. Russo. We have one, I'll take one more question from Michael Kozlowski.
Yes, I really liked your sandwich reinforcement approach. I think that's extremely important. I think we often forget that we are shaping behavior as well as grading behavior. And I found it helpful sometimes to, I guess this isn't really a question, this is like my opinion thing, but anyway, I found it useful sometimes to, even if they haven't done anything remarkable, to just choose the best thing they did. And I think that's what you're referring to. I think that's really important, to just choose the best thing they've done and reinforce that, and then use that to motivate them to improve in other areas. And I think that this should also, if you can make this appear in some way on their Meditrex, at least in the comments, that's also very useful, because that's even more, or there, however you do your evaluations, because that's even a more significant comment or reinforcement for them.
Yeah. Yes, I agree. A little bit of positive feedback can go a long way. Sometimes students will harp on all of the negative comments, but if we are able to give any type of the positive feedback, that can go a long way. Agreed.
That's a great question. It's a learned skill for a preceptor also, to learn to find those positive things when you're just kind of stressed and kind of mad. That's really a good skill to find those things. Great. Thank you so much, Dr. Steinway. Let's move on to introduce Dr. Adam Blacker. Dr. Blacker is originally from Idaho. He attended Brigham Young University in Provo, Utah, and graduated with a bachelor's degree in Spanish. After BYU, he attended the Ohio State University College of Optometry and graduated in 2009. He is an associate professor at the Arizona College of Optometry at Midwestern University in Glendale, Arizona. He's been married to his sweetheart, Sherry, for 16 years, and they are the very proud parents of 4 children. I am pleased to turn it over now to you, Dr. Blacker.
All right. Thanks, Dr. Moy. Thanks for the introduction. Thanks to all those at ASCO for making this forum happen and allowing me to be a part of it. I teach in the 3rd year clinic at ASCOPT, and I'm involved with the ophthalmic optics course as well as the sports vision course here. But today I wanted to share some of the strategies on how to deal with students that may be struggling. So during lecture or clinical encounters, after information is presented, the educator obviously hopes that the student learned all they were supposed to. An easy way to check if that happened is to ask, does that make sense? Now, truth be told, the learner will probably say yes, no matter what. There's too much at stake in answering this question with a no. In the student's mind, a no might lead to the teacher thinking that they are dumb, or even worse, a no might prolong all this awkward one-on-one conversations that they might be getting from a preceptor. So does that make sense is not that great of a question. And it's not just a bad question because of the potential for flawed responses, but it shouldn't be the ultimate goal for us educators to merely make sense of the material. This is kind of too low of a hanging fruit. And so I like to remind students that things will make sense because number one, the things I'm teaching are true. Number two, they're smart enough to understand them. And number three, I'm an effective communicator. But things making sense doesn't mean the student owns the information. And that's really what we need our students to do, is own the information and become skilled with it. This means that they come across something new or unfamiliar, they don't fall apart, they start to assimilate this new information or experience with what they already know. I think about a paintbrush sometimes. The idea of a paintbrush makes sense. Most of us can go and buy one and own one, but we need a little skill to start going from shapes to portraits. Making these types of categorical distinctions in knowledge for students is important because often, and it was already mentioned, especially for those students that struggle, self-reflection is not as precise a tool as you would hope it would be. I kind of tell the students, and I kind of remind myself, they don't know what they don't know until they find out they don't know it. So there has to be a way to assess how well these students own the information we're presenting them. One way of assessing the ownership of skills is clinical observations. And I want to make a distinction between observation and precepting. When we're precepting, we don't always get the chance to actually assess the students' skills in the clinic or their interactions with patients. We kind of have to make a lot of assumptions based on the data that they're giving us. But when we're in the room observing, our assessment is informed by actual information. One thing we do here at ASCO is we have a mentor program. In this program, faculty members are assigned 3 to 4 students to guide through their third-year clinical experiences. One of the ways we do this is by observing them perform a comprehensive eye exam during their clinical encounters. Mentors aren't precepting, and so no official grade is assigned during these experiences, but a mentor by the mentor, but students still present and communicate with attending doctors. These exams are a great time to review and improve skills in the appropriate setting, which is great for those tactile and visual learners. These are some of my notes directed to a student after one of these encounters, and it looks like a lot of writing, and it is on purpose. It's important to catch everything and then provide detailed written documentation. I asked the struggling student to work on certain things and for them to review this document before future encounters so they don't forget to correct anything that was already discovered. I let them know that making the same mistake a second time could be interpreted as carelessness. And so they need to review their feedback, whether it's through MediTrek or whether it's through an email like this, so that they're not making that same mistake twice, because that's not an accident. They have to keep their skills sharp. They have to address their shortcomings. And so I try to approach this type of feedback with what I call kind candor. I'm optimistic. I believe in their success as long as they do these things that I've observed and recommended. I don't hold back on the things that they need to improve on. I feel like it's my job to be precise and critical, but not cruel. Not because I like to see them fail, but because I like to see them succeed. I'm a dad, and I always tell my kids that the day that I stop trying to teach them and trying to help them is the day that I've done caring, and that's never going to happen. And so I kind of take that same approach in the educational aspect. My approach to some of the feedback here is informed by Peter Drucker's statement that you can only improve what you measure. And as you can see here, I've tried to inform them on acceptable amounts of time to perform these tasks because of Parkinson's law. Parkinson's law says that work will expand to fill the time allotted for its completion. So, for example, if you look at that small maze in the corner, if I gave all of us here 20 seconds to connect the number 1 to number 2 with a line, you'd go through that maze comfortably and easily, knowing well that this is way too much time to complete this maze. But if I gave us 2 seconds, that restriction and that parameter might spark some creativity. You may skip the maze altogether and just draw a line going up and then to the right to connect 1 to 2. Giving the students a reference on how quickly they should be for certain skills is not just a good idea, but it's actually necessary for their success. We often do this during practical exams, but the students are usually given a more generous amount of time to perform their skill. And if an updated, realistic time isn't provided them, they may struggle with efficiency in their clinical encounters. Clinical observations can help assess gaps in skills, but not all the time do preceptors get to discover gaps in knowledge. Their knowledge of certain diagnoses may never come up in your clinic because they aren't exposed to patients with those conditions. Say, for example, thyroid eye disease. This is an activity that I gave recently during our case studies course. Outside the circle are movable text boxes that contain clinical information, signs and symptoms, and things like that. I instructed the students to take a few minutes with their groups, prioritize the clinical information in the following ways. Things that are definitely associated with thyroid eye disease and kind of trigger a strong connection to the disease, they should go inside the circle and above the line. The things that could be associated with the disease under certain conditions or have a smaller likelihood go inside the circle, but below the line. And all the things that don't have much to do with the disease go outside the circle. Then after their discussions, I show them my slides, and I gave them instructions when I showed them my slide to not change anything on their slide. So here's my slide. And then I went group to group and I said, I want you to identify something different. I didn't say wrong, but I want you to identify something different between your slide and mine. And what is it? One group said that they put hypothyroid and euthyroid outside the circle. And I asked why. And they said, because how can you have thyroid eye issues if you don't, how can you have thyroid eye issues if you don't have thyroid issues? It's a logical thought. And I love it when students use logic. It's kind of a rare thing. And so I told them, that's very logical. But did you know that a small percentage, it's not the norm, but a small percentage of patients can have thyroid eye disease with normal or below normal thyroid levels? That's why I call this activity gap identification. It works well because students have to commit to an answer. And then we are comparing things that are kind of out of alignment. This is a quick and a visual way to identify gaps in understanding. No time is wasted on the stuff we already know and agree on, but we are spending time completing their knowledge base. And sometimes these remaining bits can be the critical cues that experienced docs will pick up on. This activity can fill knowledge gaps quicker than maybe a review lecture, and you can have more meaningful discussions to complete the knowledge base on certain pathology processes. It's great in a group setting, but it's also great on an individual setting, or via email if you're having to help people in a restricted schedule climate. Another thing that should be considered when we're working with these students is that it isn't always the difficulty of the material that creates a struggling student. It can be their weakness in organizing the information for retention and recall. Let's be honest, it is likely that the students we teach have received all the information necessary to pass tests, but their inability to retain or recall information might be a larger contributing factor to their struggles than their inability to understand. Let me show you what I mean here. I've got a picture of an electron microscope image of an optometry student's brain. Here it is. You can see all the PowerPoint slide presentations covering corneal issues organized in alphabetical order. Or maybe it's organized in another student's, maybe it's organized that way because that's how Kansky's or Will's organized it for them. Maybe it's organized anterior to posterior because that's the way that was presented to them. Now, this is a sensible approach to content delivery, but not a great way to organize it for retention and recall. This is the same information organized in a preceptor's brain. Now, this info is organized by a simple, maybe yet sophisticated combination of symptoms, signs, findings, clinical associations, or the progressive nature of the disease. Organization of this kind can allow the preceptor to identify the correct diagnosis quicker, even when deciding between two diseases that often mimic each other. So by helping our students organize the information clinically, it can turn information that looks like this, and this dot to dot, to something that looks like this. Spoiler alert, that's a star. By helping the student organize the information, we take away perceived randomness in that information. And let's be honest, when we first learned all this stuff, there was a lot of perceived randomness to all this education we were getting. By eliminating the noise, we can help them find the signal a little bit easier. One way to help this is their clinical presentations to the preceptor. How many times have you heard a presentation like this? Doc, I have a 23-year-old Black female, and that's the only consistent thing that you hear. After that, it could be just a modge podge of anything. Mom's surgical history, binocular balance for an 83-year-old pseudo fake. Who knows what you're going to hear? It could just be anything. Thank goodness for the demographic information that provides some structure and at least an intro for the students to begin their discussion. But by helping them organize their presentation, they begin to bring the dots closer together. And the advantage of that is this allows them to connect them dots themselves rather than having you do it for them. So to help them with their presentation, this is the tool that I use. I call this the Blacker matrix of clinical presentation. Now, honestly, something similar may exist in the annals of optometric education. I'm not aware of it. I'm not trying to plagiarize anything, but go ahead, feel free to call it the Blacker matrix of clinical presentation. Burgermeister took my papilla, Mittendorf named my dot. Here is the Blacker matrix of clinical presentation. It's just a 2x2 matrix of signs and symptoms, but it helps the students prioritize the information that they are going to present in a way that is more clinically relevant. Things that should be presented first are, and the things that are presented first are what the patient said and the corresponding findings. This is chief complaint. They came in with blur. I found this level of myopia or this visual acuity uncorrected. This is the good customer service stuff that comes first. Things they said combined with things you found about what they said. Next are the potential surprises. Things they didn't necessarily say in their history, but things that the student discovered. They didn't mention smoking. They didn't mention a family history of macular degeneration, but I'm finding drusen near the macula. That's stuff I want to hear, and that's stuff I want to hear early on in the presentation. Or things like potential education opportunities. They mentioned a family history of glaucoma, or maybe they mentioned a history of hot elevated IOPs in previous exams. But my findings today show, again, these are things that I also want to hear early on, because that's kind of why they're coming in, and I want to be able to facilitate the purpose for the eye exam in the eyes of the patient, and I want the students to learn how to do that as well. Level 3, things that weren't mentioned and things that weren't discovered. This is information that sometimes students will offer when they really don't know what is pertinent. And so if you're getting information like, I have an 11-year-old patient who doesn't smoke, right? That's kind of like a no big deal finding. I would assume they're not smoking. It's important if they are smoking. I definitely want to know if my 11-year-old is smoking. But moving on, this helps them organize that information and prioritize it. And a structure of this kind can do that. It challenges them to tie together the examination findings with the results from their examination, or their examination findings from their patient's history. So it creates a moment where they have to tie those things together, where they move from being a tech to being a doctor. I've given this to students and told them to take a few minutes, maybe before coming to present to me, to organize their thoughts, to do it mentally. But honestly, I think writing it down could be even more helpful. But organizing your thoughts so that your words are organized. And the great thing is that when their words are organized, they begin to see the clinical relationship between what they've been taught in lecture and what they see in clinic, and what the patient is actually telling them. Another way to help students organize information is prioritize it based on urgency. Sometimes when information is read in a book or off a PowerPoint slide, the real emergent nature of findings just don't reach that emotional reactive center of the student. And they don't get appropriately excited about emergent findings because they don't realize they're dealing with an emergency. So I've requested some students to make what I call a PowerPoint slide deck of ocular emergency blanks. I show them a template that looks like this, and then I kind of give them a list of 10 to 15 emergencies. I don't want the information put on these blanks to be any longer than one slide with just a few bullet points. But I tell the student to file these things in their head so that they recognize emergencies in that moment, and they can recall them quicker. Remember, it's not because the content is difficult, but it's just things aren't organized in a quick recall way. So here we have the diagnosis up at the very top. They have perhaps the most critical clinical finding. Maybe this is the one thing that the majority of clinicians will identify the diagnosis by. Next is the actions you need to take, because discovering the issue is not enough. We need them to be doctors and not just observers. You got to do something about it. Imposters or confounding information or even helpful information will expedite the process. That kind of goes in the category that I call watch out fors. And then there has to be a reaction time, an appropriate reaction time. Delays are costly. Overacting can induce panic, so an appropriate range is necessary. And so here's an example that I got from a student. After completing the slides, we discuss them 2 to 3 times a week, or I'm sorry, 2 to 3 slides every week if I'm in the clinic with them once a week. But again, this is a gap identification. We're improving the info. And I'm sure there's more than 2 to 15 ocular emergencies that we could come up with, but depending on the clinic that they're in or the demographic that they're going to be serving, that number could probably be altered. But it's just important for students to prioritize these essential findings for diagnoses that are vision or life-threatening so that it hits that reactive core center. These diagnoses need to have an elevated place in their mind, and they can't kind of blend in with all the other things that they've been taught. So with those tools presented, let me close with maybe the final and what I feel is potentially the most helpful slide. When working with the struggling student, it's important to create a realistic expectation for the student and for yourself. You can't expect the struggling student to perform like the valedictorian after your interventions, but you can expect them and you should strive to remediate them back to the mean of their class. I think creating a candid, kind, optimistic, realistic setting for them does allow them to make the most of their remediation opportunities and progress forward with a good feeling of who they are and what they're capable of. So that's all I have.
Thank you so much, Dr. Blacker. Very original material, especially the Blacker matrix. Thank you.
Yeah, you bet.
I'd like to open this up to 1 or 2 questions. Does anyone have any questions? Okay, here's one. I find that sometimes students become overly concerned about benign findings. How do you approach those students without making it seem like those findings are unimportant?
Yeah, I honestly think that matrix can be very helpful. And again, the students that kind of, I think, are eager to present those benign findings, they're just having difficulty accurately prioritizing them. And so there are, luckily in our clinical care aspect, there are things called pertinent negatives. And so you can talk to them about there are negative findings that are relevant to the clinical care. If this person has a history of elevated IOPs, but they have healthy rim tissue, that is kind of a pertinent negative. And so those types of things should be elevated in that discussion. But that's why I kind of like that matrix, I do feel like helps elevate those types of discussions and bring them forward.
Great, thank you so much. One more question, Dr. Morelli.
Yes, can you hear me?
I can.
Okay, I'm sorry, I couldn't tell. I was using a new audio system. I loved your gap learning, the oval that you created with the thyroid, and you had all of the things that might fit into that. So can I ask you how you would, is this something that is a pre-planned activity that you would do in a classroom setting? Is this something that you would do, I'm thinking like in real time, this is going to be pretty hard to do. What kind of a setting are you doing this in? And, is it in a classroom or
Yeah.
what?
I think it's a planned activity, it's a pre-planned activity, and a lot of the heavy loading comes at the very beginning in just putting together those 2 slides, the one where they're all kind of scattered on the outside of the circle and then your own individual slide. But you can put your slide together while they're doing it. And so in real time, it really doesn't take all that much time. You just kind of I probably spent like 15-20 minutes reviewing some of the literature and creating those text boxes. And then the majority of the time spent, it was great because I felt like it had a good ROI. I put in about 15 or 20 minutes, but it yielded maybe 20 to 40 minutes of discussion. And so I felt like it had a high yield sort of aspect to it.
It seems like it would be a really good activity for team-based learning.
Oh yeah, absolutely. Small groups. I mean, this was done in an entire class. But the class was divided up into small groups. But even, in your 3 to 4 students that you have in your clinic, if you are in a glaucoma clinic and you want to use those for all the different secondary types of glaucomas, I could see a tremendous advantage in just closing those gaps very early in the clinic rotation so that you're all kind of on the same page and you can move forward with nearly identical information. Oh, it looks like we found out who created looks like Dr. Caudill. Be hearing from my attorney. Sounds good. Oh, there goes my chance for a legacy.
Well, thank you very much, Dr. Blacker. That was very informative.
Thank you.
I'd like to turn it over now to my colleague, Dr. Valerie Katouf, to moderate the second half of this forum.
Thank you, Dr. Moy. So I actually have the pleasure of introducing a dear friend and colleague, Dr. Katie Foreman, and Dr. Foreman is an ICO alum. She completed her residency in primary care and ocular disease at the Brooklyn and St. Albans VA Medical Center. After completion, she stayed on to work at the Manhattan VA campus. She's been full-time faculty at the Illinois College of Optometry for about the past 10 years. It goes so fast. For the past 3 years, she served as our primary care educational coordinator. This role centers around supporting the primary care clinical experience of the 2nd through 4th year students, including clinical case conferences, lectures, and increasingly working with remediating clinical students. So with that, I'm going to pass it on to Dr. Foreman, who is also going to bring with us an ICO student to share the student perspective.
Thank you, Dr. Katouf. So I'm going to focus today on the mental side of working with a struggling student. My talk is basically broken down into 2 parts. The first part being kind of the mental burden that some students feel about being identified as a struggling clinician and how that impacts that can play a role in their performance, and how clinical enhancement impacts their confidence as a clinician. So as Dr. Katouf said, I am welcoming Jason Dunn. I'm so happy to have him speak with me today. Jason is a 2018 Troy University graduate. He's a 4th year ICO student, of course, and he may be considered a non-traditional student. He had over a decade-long career remodeling homes before considering a career in optometry. So he's currently on externship at the Villages VA in the Villages, Florida. And he says he loves his new profession. Jason did clinical enhancement with me early on during his 3rd year. So he's going to be sharing his perspective as a student as we kind of talk about this mental impact. Okay. There it goes. Sorry. So every institution is responsible for ensuring that it will graduate learners that fulfill its social responsibility for high quality, safe, professional optometric care. I'm sure that this statement kind of embodies the mission of all optometry schools. We know, as Dr. Blacker said, our job is to kind of elevate these struggling students to the level of their peers. We need to send them out into the world as competent clinicians. I want to mention that, so at ICO, kind of if our student is identified in clinic as being a struggling student, but they're not actually failed, they're referred for what we call clinical enhancement. So the term remediation is reserved for our students who actually fail and are enrolled in something more formal. And I bring this up only because I'm probably going to use these 2 terms interchangeably. So research indicates that struggling students often have more negative emotions, frustration, anxiety, boredom. Often our students at this academic level or this education level are not used to having academic difficulties, right? They're reluctant to come forward. They're reluctant to acknowledge that there even is an issue, as somebody brought up in a question earlier. They may have a disproportionate response when being referred for remediation or enhancement. I've seen intense sadness, lots of tears, crying, shame, anger. These students often have a propensity to blame external factors or minimize, whether it's an attending who does not like them, or one attending one quarter told them to do something one way and somebody else has said it a different way, or they were taught one way in lab and that's not the way it's being done in clinic, and that's why they're failing. So their expectations are perhaps a bit unclear. Sometimes, perhaps more rarely, but there's a concern over financial burden. What happens if I'm referred for remediation, I fail clinic, I have to have extra time of schooling. So that's often an issue. And then the big one, of course, is the fear of the stigma as being identified as a struggling student, how their faculty or peers will look at them. This actually came up this morning. I talked to our 3rd year students for our primary care conference. And, this was our first meeting of the quarter. And this came up from students this morning. What happens if I do, already worried before they're even referred, like, is it going to be on my transcript? Will other people be aware? Will they know? And then, as Amy also said at the beginning when she touched on this, there's these non-academic factors that impact all of our students. There's struggling students often have these concomitant vulnerable social, personal situations, anxiety, stress that add to their struggles. So all of these factors like serve as an initial barrier to even starting any sort of intervention. So for my presentation today, to kind of get a better grasp on the true feelings of students, I did send out a survey to a group of students who underwent clinical enhancement or remediation, a combo at ICO for primary clinic the last year, or some to the year before. So I have a small sample, only 8 responses so far, but I'm going to lean on these to kind of give some perspective on where students are mentally, as well as Jason's input on some of these things. So here you can see of the students who answered, the bulk were referred by faculty for enhancement. We have the option in ICO for students to refer themselves if they personally feel like they're struggling. It is not a robust group of students who have this sort of self-reflection, but there are a few. And then you can see here that when considering whether or not they agreed with being referred, the majority either strongly disagreed or disagreed upon being referred. So there's that disconnect between the faculty perception and the student perception of where they are at. This graph here shows some adjectives that they used to describe how they felt for referral. So the most common being ashamed and confused. So here I'm going to ask Jason to speak up and just kind of about your own experience with being referred for clinical enhancement and whether you agreed at the time, you were caught off guard.
I was originally kind of frustrated. I didn't understand why like, all my hard work in the classroom, I was doing good in classes, why I wasn't translating to being good in clinic. I was seeing everyone else kind of, start to excel, and I felt like I was maybe even regressing. So I think what made it kind of an easier pill to swallow was how it was presented to me. And my attending and I, we met at the end of the quarter, and I told her I didn't think I was where I should be. We kind of came to the conclusion together that I could use some additional help. So it kind of switched into relief pretty quick, especially after talking with Dr. Foreman. We kind of game planned and strategized, and I realized like this is really in my best interest. And it made it kind of acceptable. I was definitely a little bit ashamed or embarrassed at the beginning, but I mean, once I started seeing that I was progressing, my confidence was getting better, and started seeing some of that. It really, by like week 2 or 3, I was in a different mindset for it altogether. That it was like I was really on board, especially by like the second or third week for sure.
Thanks, Jason. I'm curious, do you think also, talking about the stigma, do you think that there is with students a stigma attached to?
At first, for sure. I think a lot of them don't know maybe what it is or what they're doing or why they were put in it. I don't think a lot of them know that you can refer yourself, or it's not a punishment, and what you get to do is, it's super valuable time. So I think when I started talking to more people about it and they understood, they're like, oh, I would like to do that, or that sounds super useful and helpful. So it really, I mean, after a while, I went from, not talking about it to I really wouldn't shut up about it. I referred a lot of people to Dr. Foreman or their attending, like, you should talk to them. They got some cool stuff that you can do that, there's no reason you should be doing what I was doing, just living in anxiety and, having a rough go at it. So, yeah, that's pretty much how I felt and would tell people eventually.
Okay, great. Thanks, Jason. So, again, like I think just these few kind of points or slides about kind of the baseline just shows, highlights that there's this kind of emotional or self-awareness hurdle that we all probably faced even initiating any sort of enhancement or remediation. Sorry. Okay, so I'm going to pivot now to this other part and the mental impact of maybe a more positive one, and how we move the needle in regards to confidence levels when we talk with these students. So, with struggling students, we have so many ways that we assess clinical competence, right? Before they're in clinic, we have the lab practicals, rigorous practicals that make sure they can do the skills accurately, safely. In clinic, we, as attendings, we're watching their abilities to conduct an exam, how they perform, the skills on patients, are they making decisions accurately? And we give them the feedback with MetaTrack or verbal feedback and enhancement more so. I rely a lot on clinic observations, going through case reviews, as well as other tactics to kind of assess their competency. But because they're getting by on that does not mean that they are a competent clinician, right? The same way that you can have an overcompetent clinician with poor skills or reckless behavior. So, and there are a lot of factors. This is just kind of a definition, a Webster definition of confidence. There's so many clinical situations that can impact the student's confidence. There's the outside factors, whatever's going on in their life, the emotion that's kind of, lurking there on the side, their knowledge base, patient dynamic. If they have a tough patient, the dynamic with their attending doctor, with their peers in the conference room. So we do expect these small variances in competence in relation to situations. They're normal, they're warranted, but when we get these large shifts or total absence, that's where we run into trouble. With clinical competence plays this role in a student being able to meet the needs of their patients, to be just successful overall in clinic. So our undercompetent clinicians, they have a hard time making decisions. They spend a lot of excessive time gathering data that we already know. So enhancement, in my opinion, kind of provides this safe space for students lacking in confidence to build on it, whether or not it's conscious or it's just a byproduct of the extra work that they put in. So for the survey here that I did, the areas that I looked at were clinical skills, test selection, data analysis, diagnosis, management, communication. This kind of mimics our MetaTrack rubric. So what area of clinic would you consider to be the least confident? You could see data analysis, diagnosis, management, communication. And I will tell you that little wedge of none or of other, they wrote in none. So they were totally confident in everything that before being referred. So again, there's that overconfidence coming in. And then here, the greatest improvement. Actually, let me back it up. I'm sorry, Jason, what do you think? Like, you tell me, where were you prior to starting?
I was really just kind of all over the place with my confidence. I don't feel that I was confident in anything. So I was second guessing myself on trivial stuff because I was really scared I was just going to miss something. And I wasn't going to have a leg to stand on and trying to defend any kind of diagnosis I was coming up with. I was just gathering data in the hopes that there would be a diagnosis buried in there. So I think for this one, chose test selection, but really it's probably a combination of a few of those. Yeah.
Okay, great. And then the greatest improvement was definitely communication, followed by data analysis and management. I will say we spent a lot of time, kind of one-on-one time in remediation enhancement, just talking and like role playing, lots of role playing. And so I think that's maybe where communication we see, but do you want to weigh in here as well?
Yeah, I would agree with communication. I think I got a lot better at presenting my cases and organizing my thoughts in a logical way that made sense to me and to the attending. I got to watch, actually with Dr. Katouf in pediatrics, and I got to see other students present their cases. And I got a lot out of that, not only just for test selection for BV and pediatric stuff, but just kind of like how they would go about in a logical order, presenting their findings that I really wasn't doing very well at the beginning, for sure.
Yeah, that's great. That's like, and that was another kind of tactic that we use, like with, enhancement students, like giving them the opportunity, just more exposure to different clinical situations, to different faculty, being able to kind of sit in a non kind of threatening environment, not being graded. You're just there to kind of take more in. So, oops, sorry. So here you see kind of the overall, the before and after. You know, the pre-enhancement is in that lower end, kind of the somewhat, the slightly, the not at all. So the majority are just not feeling great. And then we shifted it afterwards to moderately, somewhat at least, and then some slightly. So Jason, again, here's your turn. What's the you know, what would you say about your overall shift? I think you've kind of touched on it, but yeah.
Yeah, I feel a lot better about being wrong with something. Like at least I kind of gathered that, you know, I was just collecting data for the sake of collecting data, and I wasn't really addressing the patient's complaints and going about an exam in any kind of real good order. So once I kind of got those pieces together, everything else just kind of fell into place. And like I didn't feel like I was being overwhelmed with the data and everything else. And that really just kind of, and once that clicked in, I wasn't having anxiety. I wasn't going in there regretting going in or being anxious. Like I used to wear a sweatshirt because I'd sweat through it, my scrubs, long before I'd even get into clinic. And well, my shirt's dry now and I'm in Florida, so life's going good. I feel a lot better about stuff.
That's great. That's great. And then, you know, kind of looking here, just sorry, overall benefit, I will say that, you know, most people do end up finding the enhancement helpful. So whereas we started and people did not even think they needed it, you know, the clinical enhancement, I do think, you know, for most folks who enter it, you know, it does make a big difference. So, you know, I guess I want to ask you here kind of your thoughts on, you know, for our institution or other institutions, just considerations we should have about, you know, student remediation or student clinical enhancement.
I wouldn't really change a whole lot. I mean, I'd add basically everything Dr. Blacker said would be pretty awesome. But like the rest of it, I think was really important that I was able to talk with you and the attendings and come up and game plan and be really involved with what I thought would be most beneficial for myself. And there wasn't like you know, a regiment that I had to do that I was going to be forced into or busy work. I wasn't going to get passed along to no offense against residents or like a fourth year or something like that. It was with other attendings. It was with Dr. Foreman. So I knew then that, you know, it's a good program. And if I had to tell anything to the other students going into it, that there's really no shame in it. Like a lot of us had tutors, we worked in study groups to get help for stuff. And so it only makes sense to me that clinic would be the hardest thing because you got a lot of moving parts. It's a combination of all your knowledge you have to pull through. So get help when you can, get it early, and you know you won't have to go through maybe an additional quarter or two of, you know, really hard exams and that you're really not getting much out of. So, and the other thing is, if you're worried about time, like some of the most valuable time I've had so far was in the remediation, getting to see how or enhancement the exams go, and all the other additional stuff I got to do that most other students probably didn't get a chance to do that. And it was really only like a couple hours a week or something, depending on what I wanted to do or what we could do. So that kind of flexibility and everything too, just really, it made it easy to do. And I would definitely recommend it, you know, getting help sooner than later.
Yeah, thank you, Jason. Just to kind of touch on it from the chat, like, so when Jason talks about putting in extra time for us, it is extra time. So if students are identified as struggling or self-identify as struggling, they do put in extra time, usually at least an hour a week of meeting with myself or another faculty. And, you know, in some cases going to other clinics to observe. We kind of have a set individual plan for everybody who's doing it and kind of work through it week by week. So it's a host of things. It's, you know, sometimes it's, you know, clinic observation in addition to, you know, myself going in to observe exams or somebody else. So yeah, I think that is it for us. Does anyone have any other questions?
So Dr. Foreman, just to summarize what you said, there were a couple questions in the chat about exactly what ICO does for enhancement. And it sounds like in your response, it's really individualized. So you look at each individual and kind of see where their needs are. Is it more clinical time seeing patients? Is it one-on-one case review? Is it observing other clinicians? Is that kind of how you do it?
It is. And I think, it usually, it sets kind of like with that initial meeting. And I was thinking a question that was asked early on during, I think Dr. Russo maybe had asked, I was thinking about this for my own, that kind of mismatch, right, with students kind of self-perception and kind of getting the point across. So, a lot of times during that initial meeting, you're met with a little bit like you're up against a wall. They don't necessarily see what the issue is, or they don't want to be there. They don't have the time. So I do think, Dr. Steinway had said, like, going in to observe them and being there and having that kind of, solid or like tangible kind of evidence to back you up. So those two things are kind of for everybody. We start with a meeting to discuss, and then kind of an observation. And then from there, we kind of pick it apart. And a lot of it, is, like I said, kind of like this, just going through cases or, acting out cases, but it's whatever each individual needs. Like if there's a particular area of weakness, that kind of helps guide us. And
yeah, thanks. And then we have a question, a raised hand from Dr. Morelli, Danica Morelli.
Thank you. Jason, I think we've all, or many of us have posted in the chat, but I really want to again say thank you to you. To have somebody come in who's gone through this and we're not hearing it from the professor's perspective is really so meaningful, and I'm really grateful to you. My question for Dr. Foreman is, how do you know when when a student is finished with enhancement? So is this a prescribed amount of time? Is there a goal? And can you sort of address how you structure this for your students?
Yeah, that is a fabulous question, because that is probably the hardest thing to kind of sort out. There is not it's again, case by case, and it really is just it's like a dialogue with faculty. It's, I lean a lot on the written review from MetaTrack. I do read those every week, and I see, like, are we kind of shifting things there? I'm in constant communication with their attending doctors that quarter. And some of it's just the student. How are they doing? So there is no, like a retest or anything like that. So for some students, it's a quarter. I had students I worked with the entire year last year, and kind of they're, on the radar of the person who works with the students out on externship. So it really is just kind of more, my colleagues who are working with them in clinic, leaning on them to say, what do you think? Is the student, kind of at the level of their peers? With Jason, I can tell you, like, he had like a fabulous review from his final, evaluation from his attending, suggesting residency. And I was like, I feel like you're probably okay. You're doing fine. And he felt, good. So I think that's all I can really lean on right now.
All right, well, I'm going to go ahead. I know we have so many questions. It's been a great presentation. I'm going to stop there, but I do want to close it just by asking you, Jason, it looks like you really made that switch. You used the word mindset, and that really struck me, from entering clinically with a fear mindset, kind of afraid of what you're going to approach, to now leading with confidence. How has that changed just your whole educational experience, and what's going forward in your career?
I love it now. Like, I was really questioning optometry, and I was like, I had some odd thoughts for a while, but I love it now. I like what I'm doing. I really feel like it's saved the rest of my third year from being really bad. So I'm really grateful for the experience and that I got to go through it. It may not seem like that when I was first starting, for sure, but I really wish students that are struggling could see that it really is like the school wants to see you help or see you succeed. Everyone's there, they got your back, and that's what they're there for. So you don't have to do it alone. You don't have to feel like you're on an island or anything. Just And that really helped me just knowing that the schools that you guys were there for it.
Yeah. Well, thank you. Thank you, Jason, for taking the time. And Dr. Foreman, that was a wonderful presentation, really pulling together exactly what we're talking about. So thank you both. All right, so we're going to move on to Dr. Jennifer Riley, and Dr. Riley is an assistant professor of optometry at the New England College of Optometry. She completed her residency in primary eye care and ocular disease in 2017 and has been at NECO ever since. She currently serves as the instructor of record for multiple courses at NECO. Dr. Riley is the director of optometry at Boston Children's Hospital, and she spends half of her week in the clinic seeing patients and precepting second, third, and fourth year students. In her primary area of interest and research is in optometric education. So today, Dr. Riley is going to talk to us on the topic of providing effective feedback to struggling students. So thank you, Dr. Riley.
Thank you, Dr. Katouf. So we'll be talking about providing effective feedback today. And so I want to thank you all for being here, but also congratulate you on being here, because optometry is such a wonderful community, and I find optometric education is the same. So some of you may know Jodi Picoult as a teen novel author, but she actually got a graduate degree in education from Harvard University. And she says the fact that you worry about being a good teacher means that you already are one. So I think it's great to see so many educators here together. And through the chat, the feedback is great and sharing resources. So I think what's nice about, this closing part of the panel is that we've really come full circle. So Dr. Steinway started us off with setting expectations, and really setting expectations is the key to providing effective feedback to students. It's really important that the feedback that you give aligns with those initial expectations. So feedback is really useless unless you've really set a good foundation for what you're about to provide to your students. It's also important that your didactic and clinical teams have open communication and not work in silos, so that our clinical preceptors and educators know exactly what's being done in the labs, and so the expectations are consistent between the two. With good education, just like good management, it's important that any of the feedback that you provide shouldn't be a surprise to the student. Now, I know Dr. Russo had talked about awareness, and sometimes the student's perception of performance doesn't always match the preceptor's perception of performance. And I'll talk a little bit about that, and how I think really listening and hearing what they have to say and giving them a chance to be part of that conversation can be really helpful in that area. So as Dr. Katouf said, I'm the clinic director at the Martha Elliott Health Center of Boston Children's Hospital. And so, when I work with employees, it's the exact same thing. I should never really catch them off guard with any of the feedback that I provide. So some general tips for effective feedback. As educators, know the power of your words and your tone. So I included the picture of the book here, Dare to Lead. If you haven't read it, I highly recommend it. It's by Dr. Brene Brown, who's out of Houston, Texas. And in it, she actually talks about how 80% of adults have a creative scar that usually is due to an educational experience. And when I actually listened to this in audiobook, but when I heard that, this really stuck with me. And I was like, wow, I have one myself. I remember when I was a sophomore in high school, my English teacher told me I was a terrible writer. I was never going to be a good writer, and to stick to math and science, which I was good at. And I believed that for about 10 years before I realized that maybe that's not true. So as educators, be careful of your words. Think about what you say, because it's going to stick with your students. Your feedback should be thoughtful and constructive, and you want to make sure that you're identifying strengths equally to identifying areas of opportunity. So as I think it was Dr. Kozlowski was saying earlier, with positive affirmative feedback, which I'll talk about, it's equally as important as the constructive feedback that you provide. And it has to be in both written and verbal form. So for your verbal feedback, this should be very frequent, when possible. It's really that in the moment, teaching moment, that verbal feedback. So you want to make sure you find a time, when it's appropriate at the end of the session, of course, never in front of the patient. But it's very personal. And so it's less formal, but equally important to the written feedback that you provide. It's really more of, for those in education, a formative assessment. So formative assessments typically are low stakes feedback along the way throughout your course, as opposed to a summative assessment, which is kind of a formal assessment at the end or midway through the course that provides you as the instructor feedback, as well as the students. So written feedback is typically less frequent, but should be utilized more when you're working with a struggling student. So that can be in the form of email, evaluations, and we'll talk a little bit more about that. And early communication with clear goals is essential. So a couple more comments on verbal feedback. There really should be a cycle here between your verbal and your written feedback. So when you mention specific examples of what happened after a case to a student, you want to follow up with some form of, documentation, some written form of that. So whether it's an email, whether it's in a special evaluation, depending upon the need of that struggling student. And as I mentioned, you want to make sure it's in the moment when possible, because that's really when I think both parties are going to get the most out of it. It's also important that the feedback that you provide is very specific for multiple reasons. I think it really helps match the expectations that were set. But then we were also talking about students' awareness, self-awareness, and their perception. And the more specific that you can be, I think you can help close that gap to make their perception match yours. So those specific examples. Oh, whoops, sorry, I was just having trouble advancing my slide. I'll go back one. So for written feedback, just like for your verbal feedback, you want to be clear, concise, provide those specific examples, particularly in those meta-track evaluations, but you want to make sure that you mention it even before that so that it doesn't catch the student off guard, which I was mentioning is an important part of effective feedback. So some teams I know, if multiple preceptors are working with a student, sometimes will share comments with each other, of course, in a protected form. But that can be helpful as well. And so when written feedback is provided, it's really important to follow up with the student verbally. So again, that cycle to ensure that they understood what you said. The student needs to own the information, as Dr. Blacker was talking about. And so it's sometimes hard to tell just by providing written feedback if the student truly understands it and accepts what you're providing for that feedback. So having that verbal conversation afterward is very important. You want to make sure that this is done early for your struggling students. So the specific feedback, specific examples of exactly what needs to be done, particularly, I think we've all mentioned Metatrek at this point in those evaluations, because not only will it be reviewed by the student, but unfortunately, sometimes for struggling students, this may be reviewed by, whether it's a student affairs committee or groups of people who are determining their path forward. And so having those specific details and examples, I think, are really key to help everyone stay on the same page and have a good picture of what's going on here. I know Dr. Foreman was even talking about using them in the enhancement, tutors may use them as well. So having this feedback documented with very specific examples is important. So I'm going to provide you with 5 steps of what I think will provide best practices for effective feedback. So maybe I could call these the Riley steps for effective feedback if Dr. Blacker gets a square. So each of these, I think, kind of increases in your ability to be someone who provides effective feedback. So if there's anything that you remember from my part of this panel, is that feedback has to be constructive and productive. And I'll talk about what that means. And then interactive, repetitive, and affirmative only kind of provides these, even more layers for your feedback to a student. So a lot of people think about feedback as either affirmative, positive, or negative constructive. But constructive feedback doesn't necessarily always have to be negative. And we'll talk about that when we're talking about making it productive and what that means. I think there's even some debate in the literature on that. So constructive feedback, though, it's a necessary evil, right? We're all teachers, we're all educators. We have to provide some form of it. Whenever someone's learning, it's part of it, whether you're a coach, a teacher, whatever it may be. Constructive feedback is really when you're identifying the specific areas of opportunity for that particular student. And so, is it a particular skill that they're having trouble with, a technical skill, an analytical ability, communication, and then, even going more detailed beyond that. If it's communication, is it their case presentation? Is it, their documentation and the electronic health record? So you want to try to get it down to as fine of a detail. Dr. Steinway was talking about specific rubrics are helpful in these instances. Providing constructive feedback, some people view it as confrontation and are uncomfortable with that. And if you're one of those people, I think here's a few books that I've listed that are helpful in that. I would certainly recommend Difficult Conversations. It's very academic, but it's very helpful if you're someone who finds, oh, I struggle in providing constructive feedback to people. So it has to be productive. So constructive and productive. Productive means that it's not enough to just identify that area of opportunity, but you also want to outline what needs to be done differently. And I know a few of the, the panelists we've talked about, sometimes you don't always want to answer it right away. You want the student to walk there and get there themselves. That's great for learning. But eventually it is important that they know the expectation and they have a clear outline on what's the path forward. How can they improve? So an example of this would be, say you have a second year intern who's struggling with their case presentation. And so if you just tell them, hey, you're struggling with case presentation, that's your struggle, that's your constructive feedback. They may not know, oh, well, am I not providing enough details? Am I just speaking too quickly? Am I out of order? So telling them exactly what you want done, again, resetting that expectation is super important. And that's the productive part of providing effective feedback. And in this productive part of providing effective feedback, it may also be, do you recommend tutoring? Do you recommend enhancement or remediation? Or what are your other specific recommendations for what the student can do to correct that constructive item that you initially identified? So maybe it's resources, external reading, etc. So that's the productive piece. So if anything, make it those. And then you want to add on, it should be interactive. So feedback with a student should really be a discussion and not a lecture. I certainly learn the most about how the students are doing based on what they tell me. So I'm an active listener, and I get a really good idea of where they're coming from and where they think they are at and where they're performing within the curriculum. So I sometimes even ask the students, identify your own strengths and weaknesses. I'll say I've come up with my own list of areas of growth and opportunity and your strengths, but what do you think they are? And then that way, if there's already a disconnect, and you can address that sooner, because it's better to address that disconnect early on than let it become a problem later when you're actually providing them with their course grade. This also confirms that they understand and acknowledge your comments and the specific examples that you have provided. So involve them in that process and that plan to achieve success. So you're kind of creating an agreement or a contract with the student in this case. And it should also be repetitive, right? So that cycle that I was talking about. So you want to follow up and document. I find one of the things I do with my struggling students is I start an email chain. I send them the initial email where I highlight their strengths, I highlight their weaknesses, and I say, and here's my plan. Here's my action items for how we're going to go forward. And then I have them acknowledge it, and I follow up verbally. And then I keep all my comments in that same email thread with the student. That way I can easily look back and see, what did we already talk about? What did the student acknowledge? What can be done differently? Now, that being said, if something is consistently done incorrectly, or that's a problem, right? And especially with adult learners, if feedback is given once or twice on something and still not being met, that's when some sort of other intervention is necessary, whether it's the clinical enhancement, tutoring, remediation, maybe even a special evaluation if you use those in MetaTrack. But really, if something is consistently being done incorrectly, you want to try to intervene before it just results in a poor grade. And have that conversation with the student before doing so. Again, it should never catch them off guard. And then finally, as Dr. Kozlowski was saying at the beginning, is that you have to provide positive feedback. You have to. Studies in almost anything have shown that you will always perform better if positive feedback is provided. I think they've even shown that plants grow more if you talk positively to them. And the same is true for us, right? If I were to tell you, imagine this was you, and I was saying, you're terrible at this. You're terrible at this. You have to fix this. How would you feel? Whereas if someone is, standing there and saying, hey, I think we need to work on this, but you're doing this really well. Or that sandwich approach that Dr. Steinway was talking about. You have to provide this affirmative feedback, both verbally and written. So make sure when you're doing that evaluation, well, yes, sometimes the first thing we go to is we start identifying all those areas of opportunity, but really spend some time to comment on their areas of growth and celebrate their successes in the clinic. So again, those Riley 5 steps for providing effective feedback: constructive, productive, interactive, repetitive, and affirmative. So now I know all of this is time consuming, right? I can write to all of you. I even saw the FTE questions in the chat. I know that this is time consuming and it's tough. And that's why I was giving you one of the ideas of, I keep it in a common email thread. That's how I keep track of my struggling students, so it's all in one place. Sometimes I even schedule send emails if I'm working on charts later and I realize there's comments I want to provide to the student, you know, I'll make sure I send it the next day, so I'm not just sending it when I'm working on that. You know, your institutions likely have a student advising team. You can talk with them for effective ways to do this so that it's not as time consuming. And also find a good clinical teaching mentor, right? You should have multiple mentors in your life. Maybe you have one for research. Maybe you have one for writing. I certainly needed one for writing at one point, apparently. But, you know, get one for clinical teaching as well. So, you know, find that person who does this well? I'm sure even colleagues at your institution say, oh, we know Dr. So-and-so is really good at providing this feedback. Talk to them, you know, figure out a way to make this effective for you. So in summary, your verbal and written feedback must be consistent with each other and with the clear expectations and goals which were set for that student. You want to make sure that you provide specific examples, so it's that productive part of the constructive feedback. So you've identified the area of opportunity, but you've also outlined an action plan and a clear path forward for their success. And providing those specific examples will really aid in that and also close that gap in, you know, maybe the disconnect in perceptions of the student and the preceptor's assessment of their performance. The feedback should never catch the student off guard. So make sure that you're always providing this feedback and as you go, and they don't all of a sudden just see a remedial or a fail in their clinical performance. And then remember to build upon those 5 steps as you're providing feedback to make it constructive, productive, interactive, repetitive, and affirmative. So these are just some of the resources and books that I was talking about, but there's certainly also leadership programs and conferences. Harvard Medical School provides a great one that I attended a couple of years ago that's particularly for clinical educators. It's a wonderful program, and I went to their impactful feedback session that they had there, which was all about using MetaTrek and grading, which was very helpful. But so at the last 5 minutes or so that we have, I'm happy to answer any questions. Thank you.
So Dr. Riley, thank you so much. I love the way you pulled in everything everyone else had said into your presentation. So that was very skillful and helpful for all of us. So are there any questions for Dr. Riley? Anyone raising their hand? Someone wrote here, Dare to Lead held my attention from cover to cover in audio form during commutes. I highly recommend it. So listening to some lectures from Brene Brown is always a good thing too. So Dr. Russo, I see your hand is up. You can go ahead and ask your question.
Hi, again.
Hi, Dr.
Thanks, Dr. Riley. That was fantastic. We've been talking about this a lot at NECO. I would say just one thing that I might add, just in my experience working with students and specifically students that are struggling clinically, in addition to trying to be as specific as possible and giving examples, because I think exactly to your point, if you're not specific enough, then students are confused about what exactly it is that you mean when, you know, you're indicating that they're struggling, but also trying to give context as to the meaning and magnitude of, you know, what they're doing well and what they're struggling with. So if they're doing something well, is, you know, how meaningful is that? You know, is what they're doing well amazing, you know, and should they keep doing that because it's totally going to change the way that they practice? And on the flip side, you know, is a mistake that they're making a really small mistake, or is it potentially vision threatening? Because what I have found when working with students is part of what fuels the confusion about the perception that they might have between their performance and the preceptor is, oh yeah, we talked about that mistake that I made. And it's like, oh, just because we talked about that mistake, it was no big deal. And it's like, you know, I'm talking with this student because I'm a sort of objective third party. I'm like, that mistake, you missed optic nerve pallor, you know, like that's a whopper of a mistake. But again, context means
Dr.
everything.
Riley, did you want to comment on context?
So yeah.
Yeah, absolutely, Dr. Russo. That's a great point. I think applying magnitude to whatever, you know, to the feedback and to the specific examples that you provide is very helpful. You know, was it like, just like you said, you know, was the mistake very minor? This is something that's easily corrected, or was this, you know, a significant issue that can have consequences if not corrected? Yeah, it's a great point, Dr. Russo.
All right, and I think we'll end. I see that I have a hand up from Dr. Michael Kozlowski, I believe. So we can ask our last question, Dr. Kozlowski.
I just wanted to say that I really liked what you said about communicating with the student and getting their buy-in to what you're trying to do. Many students I've found look at a remediation or a special program like this as sort of extra points they need to graduate from clinic without fully realizing the magnitude of their need for improvement. So I think that unless you can establish that, unless they understand, you know, that they are not performing at an adequate level, and that they can, you know, but they're going to need to change things to get there. If they view this as just as an extra credit to pass a class, it just doesn't work. So thank you for pointing that out.
Yeah, that's a great point. And I think that's where that active listening really comes in, to making sure that they feel heard and that that they then have buy-in to what not only the issues are, but then what the corrective plan and action is going to be. And I see there were a few more questions. I know we're right up on time. So
yeah, I think we're going to stop here. And thank you so much for your great presentation to everyone. I think this was just, it all integrated so beautifully, and I'm grateful to everyone. We're getting lots of great comments in the chat. So right now, I'm going to turn things over to Dr. Feiss and ask her to conclude our forum. So thank you all, presenters.
I just want to thank everyone. Again, thank you to the speakers, Dr. Blacker, Dr. Foreman, Dr. Riley, Dr. Steinway, and of course, Jason. We really value all of your feedback and expertise that you provided today. We're looking forward to implementing the strategies and educational pearls in our clinics, hopefully on Monday next week. If you would please fill and complete out the Survey Monkey that will be handed to you or given to you via email from Carol Brubaker. All of that information is very helpful in our planning purposes for future presentations. And so again, thank you to all the moderators, the ASCO Planning Committee, and of course the ASCO staff for this wonderful event. And I hope everyone just has a wonderful weekend. So thank you so much.
Thank you all.